Hey there, I'm Kevin Houlihan, the CEO of Workflow Services. Welcome back to ECAPS Watch. Today, I'm joined by my friend Nancy Gagliano. Nancy has an incredibly diverse background, including working as a physician at Mass General Hospital, working at the NIH, and as a senior VP at CVS as Chief Medical Officer for MinuteClinic. She has a passion for using technology to make it easier for healthcare providers to deliver exceptional care. It's great to see you again, Nancy.
Thank you.
Can you tell me about a time where you've seen a change where pharmacies have started to deliver more exceptional care that falls into your area of passion?
Sure. Thanks a lot, Kevin. This is a great topic to be talking about. It's one of my passions. So when I was at CVS, I had the great fortune to be exposed to kind of the forward vision of healthcare related to pharmacy. And it was just fascinating to see the vision of healthcare and the role of pharmacists changing over the course of time. I think a lot of pharmacists and pharmacies realized that it'd be challenging to be successful without broadening their scope. There were just so many instances. Everybody's exposed to the fact that pharmacists deliver vaccines, and that was pretty exciting about 10 years ago, but now that's pretty much old hat. But you can think about pharmacists, their ability to see what the patients are taking, understand that they have diabetes, understand that they have hypertension, understand that they're not taking medicines. One of the things I learned is that a patient typically only takes their medicines about 50% of the time. So a pharmacist can look at how often a patient is refilling their medicines, which a physician does not have easy access to, and directly impact a patient's health by talking to them about their medications. That's advancing now, and pharmacists can have deep conversations about not only their medicines, but their health, and have interactions with patients that can be extraordinarily valuable in the overall health of the patient.
So it seems like as we go through time, there's more and more examples of the paradigm sort of shifting, and the pharmacies can do more. And you mentioned that so many people now have had that experience of getting a vaccine at the pharmacy. You've been involved since before that. Can you remember some cases where all of a sudden something shifted? You talked about maybe the pharmacies playing a role in medication adherence or encouraging folks. Do you have any other examples of when, oh my gosh, if we think about this differently, there could be a huge opportunity that sits ahead of us here?
Oh, absolutely. So, my initial exposure was having nurse practitioners within the pharmacist to provide care. But particularly when COVID hit, the whole concept of, wow, first of all, a pharmacist has a PhD. They are incredibly well trained. That concept of a pharmacist doing a COVID test, doing a flu test, doing a cholesterol test, doing a glucose test, and then actually being able to treat the patient, test to treat. That came out during COVID. So people not having to go to their physician provider, go to a clinic, but actually getting what they need from the pharmacist. We're not talking about pharmacists taking over medicine and becoming clinicians, but impacting a patient directly, not only just filling a prescription, but actually interacting with the patient, doing a diagnostic test, and then treating them is something that I think is so innovative, and it's already started.
So how do you think about that interplay or the coordination between some of those services at the pharmacy and at more traditional physicians? Like, how should a physician think about that? Obviously, the pharmacies are doing more and more, and we prove that they can scale and do things like vaccine delivery. If I'm a physician or PCP, how should I think about test to treat happening for my Medicaid and Medicare patients across the country?
So I think you're highlighting a potential tension point. I understand from MinuteClinic that initially physicians were a little bit nervous about other healthcare providers getting into the diagnostic and delivery of healthcare space. But what we've learned over the time is if we focus on types of illnesses that are very straightforward, algorithmic, with having boundaries, really sick people or complex care. That's not what we're talking about. We're talking about things that are bread and butter, very easy, and documented in a way that the healthcare provider can have access to, so that they know the patient had a flu shot, the patient had a COVID shot, the patient got treated for COVID because their COVID test was positive and they didn't have any significant risk factors. Bread and butter medicine delivered, and we have an access problem in the United States that this can really help.
Yeah, so that's an interesting thing I think about the way that ECAPS is shaping up. Is it's not a free-for-all, right? There are rules and protocols and standards around who is able to get this kind of test or treat care from a, that go into other health factors that those customers and patients have. And so it's not just craziness happening, and there's structure on it. But to your point, the data needs to kind of be managed in a sensible way and shared across the continuum. And
right. I think data is really important in this environment. There are places in the country that pharmacists can prescribe birth control. We want people to have access to health care. And as long as it's within the boundaries and the PCP and the healthcare system has access to all the information, which now is supported by electronic medical records, we can make sure that people have access to safe care. And as you said, within the boundaries, right? So that the patient who is getting the care is getting something that's safe and the rest of the healthcare system is aware of it.
So when you think about these changes in the ability to deliver different kinds of care across the healthcare continuum, and there's the different providers, and you can define provider in a lot of different ways. What are some of the important things in your view that we keep in mind as we support or enable providers to do more and different things?
I think that runs the gamut. So first of all, whether you're a physician, a nurse practitioner, or a pharmacist, you are highly, highly trained. You are a very expensive resource, and what you do and how you do it needs to be, we need to understand how valuable your time is. So if you're going to add work onto a pharmacist day by having them expand what they're doing, we need to find ways for them to do it that is focused on the patient, focused on quality, but reduces the amount of administrative burden. Having said that, the administrative part of it is very important. The data, collecting the data so that we know what patient, what were the parameters, the boundaries were met, the documentation is whole, and billing is done in an appropriate way. Yeah. That infrastructure needs to be provided. From my experience with pharmacists, seconds count. They're doing 1,000 different things. We want them, if they're going to be moving more into healthcare services, we want them to provide it and to be reimbursed for it and to collect the data that's a part of it without adding to their burden.
Yeah, that's an interesting thing. So, I've been having these great conversations about this ECAPS legislation, and we're thinking about more access for Medicare patients to get test or treat across the country. And that's all very exciting. And I think about, from the perspective of a patient, it's that I can get more access to different kinds of health services in a closer, easier setting, right? So maybe I can already get my vaccine at a pharmacy. And that feels a little bit different because I go to the pharmacy to get the drugs that I need dispensed, but I'm also getting some of this care. And so there's a big shift in just broadening what a pharmacy is able to do in terms of better health outcomes. But if you peel back the layers a little bit to the mechanics of how it all works, there is this new factor around medical billing. And you brought it up a little bit and you talked about the data, but this is kind of a different thing. So what we're talking about with ECAPS is we're talking about, in part, recognizing the time that the pharmacy spends with their Medicare customers and being recognized as a provider to be able to get paid for that time. And when we start talking about time, the documentation and data requirements really change, and for kind of in a new way for the first time for a lot of folks, right?
Right.
And that's related to medical billing, but it is a bit of a different thing. And I think that might not be immediately intuitive because it feels like, oh, of course, I can just keep doing this other thing. Operationally for a pharmacy, that's a pretty big change, right?
Exactly. You know, as a provider for many, many years and working at MinuteClinic, I am acutely aware of the complexities of documentation and medical billing. And, you know, it's a pain in the neck, even if you've been in the healthcare system your entire career. Now we're talking about pharmacists who have no experience in medical documentation and in all of the rules behind medical documentation, in all of the rules behind medical billing and credentialing. And there's just so many different pieces of medical billing. That's not intuitive to a pharmacist or a pharmacy group. You know, we've been able to jury rig vaccines and other aspects of pharmacy getting into healthcare delivery. But with ECAPS, we're talking about bread and butter, traditional medical billing. And number one, I'm passionate about this. Pharmacists shouldn't be doing that work. They need the infrastructure to be able to do that. And number two, the pharmacists, if they're going into the healthcare space like this, like ECAPS, they deserve to be compensated 100% for all of the work that they do. It's complicated. So spending the time now on building the infrastructure to make it easy for the pharmacists to do this so that they can focus on the healthcare aspect, but they have the infrastructure of everything that's needed for medical billing is critical. And it's not something they know. So it's not going to be an easy transition without some help.
Yeah, I'm excited about, I mean, that's obviously what I and my team get to work on every day, and we're passionate about the ability for technology to play a role here. I like to think in analogies a lot. And I think if you think back to whatever it was, the 70s or 80s, and you wanted to book, being able to book your own airline trip,
Right.
like nearly impossible. You need to go to an expert that could help, right? But now I can do it on my phone, and it can make sure that if I want to go from Madison, Wisconsin to Bozeman, Montana, I can't accidentally book a Madison to Bozeman flight. That doesn't exist, right? I've got to do a layover somewhere else, and there's a bunch of different options. But because there's technology that enables me as a user, I can kind of navigate that on my own and figure out if I leave at this airline on this time, I stop in Chicago or whatever, I go through Minneapolis. So I think there's the same opportunity there, back to your point of let's minimize the effort for the pharmacy, but give them the tools they need so that they don't have to be an expert in all these things, and they can focus on, because what you're saying is not that they are super capable of actually
Providing the service.
Right, exactly. So let's take the stuff that's not providing the service away and put some support structure in place around to help them be able to successfully spend time with the patient, right?
Exactly. And I think that the piece that many people are not aware of, because pharmacists are successful at pharmacy billing, and they have their PBMs and they have all of the infrastructure to do that, and we've been able to jury rig. I think some people might think that it's just the next step to be able to do medical billing.
Yeah.
But medical billing is very, very complicated. That's one of the challenges within the United States. We could spend many hours on why that's so complicated and fraught with frustration. But let's have the pharmacists, just like my passion is, let's have the doctors focus on what their expertise is needed and provide the infrastructure for them to do their job well, safely, with the best interest of the patient in mind.
Yeah. Well, so one of the things that I'm most excited about with ECAPS is just the scale of it, right? We've got such a huge chunk of the US population that's covered by this single insurance company, basically, that now we open up access for all these people to go get care at the pharmacy. As you think about something sort of that size and scale, any thoughts on what that could mean either now or a couple years from now or 5 years from now? Or how do you think about that, the impact of that change happening?
Yeah, and that's a great question, because I think this is almost the tip of the iceberg. Once one door is open, once the infrastructure for CMS medical billing is laid out, then things naturally will fall from there. It's always been my experience that commercial insurers follow suit. When CMS does something, the commercial insurers follow suit. Just like patients realized that they could get their vaccines at a pharmacist, and people said, I don't need to go to my doctor. It made it so much easier. People wake up every morning and say, you know what? I think I have an upper respiratory infection. I think I have a strep infection. There are some basic bread and butter aspects of primary care that you don't necessarily need a physician who's been in training for 8 years. And once the door opens, it will open doors for other things. There is a primary care shortage in the United States. We are not talking about taking away, reimbursable health care for physicians. What this is going to do, particularly in healthcare deserts and other places where access is a problem, start opening the door to help provide access. And I just see it growing. And I do think it also will help the pharmacies' bottom line, because the pharmacies are struggling right now. They've lost a lot of their front store revenue, and there's a lot of downward pressure for the prescribing and the filling prescription costs. So I think this is the kind of the tip of the iceberg that will be good for patients and for pharmacists.
I think one of the things that's really interesting about ECAPS in particular, actually, is that some of these test to treat scenarios are time bound. So if a patient can't get access right away, they might not be able to get treatment at all, right? I mean, I think there's, like, you think about COVID and flu.
COVID, Paxlovid, and Tamiflu, and other conditions, and if they don't get in quickly, then they're not eligible for the treatment. And so let's make it easy.
Right. So for some of those folks in the country, it might be pharmacy or nothing, right? If you can't get into your PCP quickly enough, then you're not getting treatment.
Exactly. Right? Yeah. Exactly. Yep.
Yeah.
And we don't want these people to be going to the emergency room.
Right. Exactly.
Right.
That's not good for anybody.
That's not good for anybody. And this is one of the reasons why I feel pretty confident. I don't represent insurance companies, but it just would make sense for other insurers to follow suit, because it's a low cost access point to which will prevent patients from getting sicker or going to higher acuity locations.
Yep. Well, one little change at a time to continue to improve the healthcare delivery system in the U.S.
Hey, whatever we can do, right?
That's right. Well, Nancy, it was great to see you. Great to talk to you again this afternoon. Thanks for joining.
My pleasure. Always happy to chat with you, Kevin.
And we'll see you all next time on our next episode of ECAPS Watch.